This is my disclaimer statement, and this is where I come from, the Chinese university, with the Prince of Wales Hospital being our teaching hospital. I welcome all of you to visit the Prince of Wales Hospital sometime next year. This is the outline of my talk. I'm going to talk about two separate but related topics. One is on management of PPI refractory GERD, focusing on current guidelines. How should we approach patients who are not responding to PPI? And what about the role of ambulatory reflex testing? The second topic is an update on H. pylori management guidelines, basing on Maastricht 5 consensus and the Kyoto consensus. So in terms of the management of difficult GERD, according to the WHO guideline, I want to highlight a few important principles for our colleagues here in Vietnam. First of all, PPI trial. Often we prescribe 1 to 2 week course of high-dose PPI. In fact, it's shown to be neither sensitive nor specific and should no longer be recommended. Instead, we should aim for an 8-week course of full-dose PPI to determine if the symptoms of GERD will respond to treatment. The other is related to H. pylori testing. Given the fact that we have a high prevalence of H. pylori infection in Asia, peptic ulcer and cancer are equally important. Therefore, chronic PPI users should have their H. pylori status checked and treated the infection to prevent worsening of gastritis. The third one I want to highlight is the use of upper endoscopy. We often in Asia advocate EGD first approach because we have a higher prevalence of peptic ulcer disease and the concern for cancer is high. Regarding the approach to the management of PPI refractory GERD in Asia, I would like to draw your attention to the third Asia-Pacific consensus on GERD management. This is how we define PPI refractory GERD. It is defined as persistent and troublesome GERD symptoms not responding to at least 8 weeks of standard dose PPI. And it's been shown that the prevalence is around 15 to less than 40% for GERD and between 6 to 15% for erosive esophagitis. Now, how should we approach to patients who are not responsive to PPI? I believe these are three very important questions we want to ask. The first question is the patient really suffering from GERD? Often we need to revisit that diagnosis. Many patients have non-ulcerative dyspepsia are being wrongly labeled as suffering from GERD. The second question is GERD truly refractory to PPI? We have to double check patient's drug compliance. And secondly, the time of PPI intake is also very important. We have to remind our patients that they have to take the drug something like 60 minutes before meals. So once we have confirmed the diagnosis of PPI refractory GERD, then we should ask ourselves, how should we approach this condition? Now, in the ideal setting, on the left-hand side are the different causes of non-responsiveness to PPI, and on the right-hand side would be the investigations approach we should adopt. You can see that For most of the situations, we should go for motility testing, but understand that motility testing may not be widely available. So instead, where countries and locations where reflux testing is not readily available, we should also consider other options before going for esophageal function test. So in fact, many options has been proposed, such as doubling the dose of PPI or using twice daily PPI, switching to another PPI, use of modified release PPI, and other therapies such as adding an alginate antacids, using nocturnal H2 receptor antagonists, prokinetics, or even reflux inhibitors. And I would like to highlight some of these treatment options, whether they are really useful for the management of PPI refractory GERD. So what about switching to another PPI or using twice daily PPI dose? Now, this is a study from Dr. David Graham in Houston. Here, the y-axis represents the median pH greater than 4. And the x-axis represents the omeprazole equivalent doses of different types of PPI. And you can see that by increasing the PPI from once daily to twice daily dose, you can see the median percentage time pH greater than 4 has substantially improved, implying that twice daily PPI is definitely more effective for bringing up a more constant intragastric pH greater than 4. And what about the different PPIs? If you can see here, if I want to maintain a pH of at least 80 to 90% above 4, it appears that esomeprazole is the drug of choice. On the other hand, for drugs such as pantoprazole and lansoprazole, even with twice daily dosing, only 50 to less than 70% of time, the pH could be maintained above 4. So in case your patient does not respond to one PPI, it is rational approach to switch to a twice daily dosing and also consider switching to another PPI to see if your patient will have a better response. What about using modified release PPI such as Dexa? This is a PPI that is released at 2 different pH levels. How effective is this kind of modified release PPI? Again, if we look at the median percentage time pH above 4, you can see, surprisingly, even with up to 90 milligrams of dexlansoprazole, the effective dosage of omeprazole is only around 10 milligrams. So in other words, despite the very appealing pharmacokinetic profile of modified release PPI, current data do not seem to suggest that modified release PPI can maintain a better pH control compared to other forms of PPI. So what about using alginate antacid combination? In fact, studies have shown that by combining an alginate with antacids will form a physical barrier as shown by the purple color over the proximal stomach. You can see on the left-hand side that this alginate clogs at the GE junction and forms a physical barrier to reduce acid reflux back into the esophagus. Whereas if you use just regular antacids, most of the ataxis after swallowing will stay in the antrum instead. So one should consider adding an alginate in addition to PPI if your patient is not responding to PPI alone. H2 receptor antagonist is often added at nighttime for patients with nocturnal acid reflux. But according to this study, it has been shown that with frequent regular use of H2RA, you can see there is rapid tolerance as shown by the solid line, that the pH rapidly goes below 4 with a few days of regular usage of H2 receptor antagonists, suggesting that regular use of H2RA even at night time is not going to help your patient. So what about other medical therapy such as prokinetic agents and reflux inhibitor? To cut the long story short, there's really no significant benefit of prokinetics in PPI non-responders. And in terms of reflux inhibitors such as glycogen, it is really not superior to placebo for symptom relief. What about the role of reflux testing for patients with PPI refractory symptoms? I understand we have a speaker who will later this morning talk about different types of reflux testing. So I just want to refer our colleagues to this ambulatory reflux monitoring for diagnosis of reflux disease according to the Portal consensus. But I'm not going to talk about it in detail now. So this is really the management algorithm in regions with limited access to functional testing. So the important thing is, if your patient is having a non-responsiveness to PPI, one should consider endoscopy. It has not been done. And also, with endoscopy, we can rule out the possibility of peptic ulcer, upper GI cancer, and also assess the severity of reflux. In patients who have a negative endoscopy, we should consider the following options, such as optimizing acid-suppressive therapy, using twice daily dose, or switching to another PPI. Adding an alginate would be quite useful, but unfortunately using bedtime H2RA or other reflux inhibitor has not shown to be effective. In selected patients, one may even want to consider use of pain modulator, including tricyclic antidepressants. And for those who do not respond to the above therapy, then we want to consider referring the patient for functional testing before surgery. So what about the role of anti-reflux surgery? Now, the important message is, according to this large-scale study, it shows that in terms of patient remaining in remission after randomization, there's really no advantage of anti-reflux surgery over PPI therapy. So please do not refer your patients who do not respond to PPI for anti-reflux surgery. The patient will end up having more post-surgical symptoms, and on his acid reflux symptoms won't be respond to anti-reflux surgery. In fact, there are advances in non-surgical treatment of reflux disease that aim to enhance the lower esophageal sphincter function. For example, this LES electrical stimulation called endostim has been used, and initial results show to be pretty promising. Another option is the use of magnetic sphincter augmentation. Again, with this magnetic ring around the LES, some early data suggests that it may be useful to enhance the lower esophageal sphincter pressure. And certainly, in selected patients, one may consider doing anti-reflux mucosectomy. With this circumferential resection of the mucosa, including submucosa, one can effectively cause fibrosis around the LES and induces a higher lower esophageal sphincter pressure. So I believe more data will be needed before these alternative options should be considered for the management of PPI refractory GERD disease. So, in summary, for the management of refractory GERD, we should really focus and revisit the patient's symptom to ensure we make the right diagnosis. And we should consider a trial of tri-state PPI or adding an alginate. Esophageal biopsies only in selected cases if you really suspect the patient is suffering from eosinophilic esophagitis, which is uncommon in this part of the world so far. Reflex and motility testing in PPI non-responders I'll leave it to my subsequent speaker. And remember, you should only consider surgery if the patient has a positive reflux testing. Don't send your patients who have a negative reflux testing and non-responsiveness to PPI for surgery. And don't forget to screen for concomitant obstructive sleep apnea and anxiety disorder, because these patients often give similar type of symptoms. And a trial of antidepressants if reflux testing negative and if the patient has got features of anxiety disorder. And I would like to go to H. pylori infection, which is still a global burden, as shown by the prevalence of the disease in different parts of the world, including Asia. I believe our current challenge is failure of H.p. eradication. In fact, there are many important reasons for failure of H.p. eradication. And they include antibiotic resistance, non-compliance to drug therapy, and also the use of incorrect regimens. And among them, antibiotic resistance is a rapidly emerging challenge to the management of H.p. infection. You can see the global variation of antibiotic resistance for different antibiotics, including clarithromycin in yellow, metronidazole in green, and levofloxacin in blue. Importantly, if you look at metronidazole and clarithromycin resistance in big now, more than 30% of patients have clarithromycin resistance, and up to 80% of patients in big now have metronidazole resistance. So this is a serious problem, and the problem is increasing over the last 10 years. And according to the latest Measures 5 consensus, it clearly states that PPI clarithromycin containing triple therapy without prior susceptibility testing should be abandoned when the clarithromycin resistance rate in the region is more than 15%. So in other words, in countries like Vietnam with a high local clarithromycin resistance, we should no longer use PPI clarithromycin containing triple therapy for your patients. So what should we do for our patient in terms of the first line treatment for H.p. eradication? As I mentioned earlier, in areas with low clarithromycin resistance, such as less than 15%, we can continue to use the standard PPI and oxyl clarithromycin therapy. But for areas with high clarithromycin resistance like the NAM, if the region has a low metronidazole resistance less than 15%, one can consider either bismuth quadruple therapy or concomitant non-bismuth quadruple therapy. On the other hand, if your region has got dual resistance to clarithromycin and metronidazole, the recommended treatment of choice would be a bismuth quadruple therapy. And regarding the optimal duration of bismuth quadruple therapy, the current message 5 consensus recommend 14 days unless 10-day therapy are proven effective locally. So remember, if 14 days of bismuth quadruple therapy as an effective first-line treatment in this country where clarithromycin resistance is high. And if for reasons bismuth cannot be used or not available, how should we choose between the different non-bismuth therapies, such as concomitant therapy, hybrid therapy, triple or sequential therapy? Again, according to the message 5 consensus, concomitant therapy using PPI, amoxicillin, clarithromycin, and a nitroglycerol administered concurrently should be the preferred non-bismuth quadruple therapy, and has been shown to be the most effective to overcome antibiotic resistance. What about improving antibiotic sensitivity? We know that antibiotic sensitivity for H.p. eradication is highly pH dependent. As we can see, by increasing the intragastric pH to more than 7, as shown on the right side of the graph, you can see the antibiotic sensitivity of clarithromycin will improve. Therefore, it is very important to use high-dose PPI for H.p. eradication. Therefore, again, according to the message 5 consensus, the use of a high-dose PPI twice daily increases the efficacy of triple therapy. In particular, esomeprazole and rabeprazole provide better overall H.p. eradication rates, especially if you use esomeprazole 40 mg twice daily, whereas rabeprazole 10 to 20 mg twice daily maintain results compared to first generation PPIs. So please try always use high dose PPI for 14 days to enhance your antibiotic sensitivity, therefore improving the eradication rates. Now, after H.p. eradication therapy, it is very important to test for successful eradication. In fact, according to both the Kyoto consensus and the message consensus, the outcome of eradication therapy should always be assessed, and preferably non-invasively, such as the use of urea graft test. In case your patient requires a volume endoscopy, a gastroenteral biopsy will be important to confirm H.p. eradication. In contrast, H. pylori serology will remain positive for up to 2 years, even after successful eradication. So do not repeat H. pylori serology test after successful H.p. eradication. And what should we do if your patient failed your first-line treatment? What are the current recommended second-line eradication therapy? Well, on the left-hand side, say if your patient has failure of PPI triple therapy or failure of non-bismuth triple therapy, current guidelines recommend the use of bismuth triple therapy. Or in case bismuth cannot be used, you can use fluoroquinolone such as levofloxacin, triple or preferably quadruple therapy. And on the other hand, if your patient has failure of bismuth quadruple therapy as the first-line treatment, then you should go for the fluoroquinolone triple or preferably quadruple therapy as your empirical second-line treatment. And in areas where the clinical resistance rate is high, one should consider a combination of bismuth with other antibiotics such as tetracycline, doxycycline, or rifampicin. And what should we do if the patient had multiple trials of eradication therapy but failed? Well, currently we recommend the use of antibiotic sensitivity testing using culture sensitivity or the PCR-based molecular test. However, we have to understand that the culture sensitivity test is time-consuming and the sensitivity is relatively low and time and labor expensive. The PPI test provides a rapid test with a high sensitivity but may not be widely available. And I'm going to briefly mention about new therapies for acid suppression. And now we have this potassium competitive acid blocker, or PCAB, which is a new class of acid suppressant. Unlike PPI, PCAB causes this reversible binding to the potassium channel. And the beauty of this PCAB is that it does not have any effect on drug interaction, and it has no effect on diet. And data have shown that lonoprazan, a PCAB, is more effective than lansoprazole in H. pylori eradication, as shown by the black bar with an eradication rate of up to 92% comparing to 75% with lansoprazole triple therapy. However, PCAB is not widely available in Asia yet, and other data, for example, this data, a retrospective study of more than 500 patients from Japan, showing that vonoprazole-based triple therapy is no better than the esomeprazole-based triple therapy for patients with severe gastric atrophy. So I believe we need more clinical data in the near future to establish the role of PCAB in the management of H. pylori eradication. So in conclusion, ladies and gentlemen, 14-day regimen preferably with high-dose PPI is recommended. Bismuth quadruple or concomitant non-bismuth quadruple therapy should be considered as first-line regimen if erythromycin resistance is high. Post-eradication testing should be routinely performed, and levofloxacin-based triple therapy is recommended as a second-line treatment after failure of bismuth quadruple therapy. Thank you very much for your attention, and I look forward to welcoming you to this year's day. Thank you.
Cảm ơn giáo sư Francisca. Giới thiệu với tất cả các đồng nghiệp, giáo sư Francisca và